following podcast is part of a certified educational activity titled Embracing Progress, Transforming Treatment, Empowering Patients, Harnessing the Potential of TROP2 Targeted Antibody Drug Conjugate Therapy in Triple-Negative Breast Cancer and HR-Positive HER2-Negative Breast Cancer. Access the entire activity and complete the post-test at peerview.com/RFN860. Downloadable slides and practice aids are also available.
Welcome to this PeerView CME activity. The topic for today's activity is Embracing Progress, Transforming Treatment, Empowering Patients by Harnessing the Potential for TROP2-Directed Antibody-Drug Conjugate Therapy in both triple-negative breast cancer and HR-positive or hormone receptor-positive HER2-negative breast cancer. I'm Komal Javeri, and I'm a breast medical oncologist from Memorial Sloan Kettering Cancer Center in New York. And joining me today is a friend and colleague, Dr. Anna Garrido-Castro. Anna?
Hello, everyone, and welcome. My name is Anna Garrido-Castro, and I'm a breast medical oncologist here at Dana-Farber Cancer Institute in Boston.
So welcome. So today for this activity, our goals include: how do we augment our knowledge on the evolving clinical role and latest clinical data supporting the use of TROP2-targeted antibody-drug conjugates in breast cancer? Second, how do we improve our skills in integrating TROP2-targeting antibody-drug conjugates in individualized treatment plans for patients with triple-negative and HR-positive HER2-negative breast cancer? And finally, how do we enhance our abilities in implementing best practices for provision of team-based, patient-centric, equitable care to all our patients with breast cancer? With that, Anna, maybe you can tell us about the rationale for why do we want to target TROP2 in the first place?
Thank you so much, Komal. So we know that TROP2 is a calcium signal transducer that in fact is expressed across cancer types, including all breast cancer subtypes. And for example, over 90% of triple-negative breast cancers and more than 60 to 70% of hormone receptor-positive HER2-negative breast cancers have expression of TROP2 on the cell surface. The mechanism of action, traditionally, of TROP2 antibody-drug conjugates is that these antibody-drug conjugates carry several molecules of highly potent cytotoxic chemotherapy linked to a monoclonal antibody that targets TROP2, and those molecules are linked to the antibody via specific cleavable linkers. So the ADC binds to TROP2 on the cell surface. That complex then gets internalized into the cancer cell and metabolized by lysosomal enzymes, releasing the payload into the cell where it can then exert its anti-tumor effects. And for many of the newer generation antibody-drug conjugates, that payload is in fact membrane permeable and can exit the cancer cell and enter adjacent tumor cells that may not necessarily express the target of the ADC in the first place. And that is the so-called bystander killing effect of antibody-drug conjugates. There are several antibody-drug conjugates targeting TROP2 that are currently in drug development, and one that is currently FDA approved, sacituzumab govitecan. So sacituzumab govitecan, or SG, binds to TROP2 and carries SN38 as its payload, which is a topoisomerase 1 inhibitor. And the drug-to-antibody ratio for SG is 8:1. Another TROP2 targeted ADC is datopotamab deruxtecan, or Dato-DXd, which carries DXd, also a topoisomerase 1 inhibitor, as its payload, and the drug-to-antibody ratio for this ADC is 4:1. And finally, we have seen recently data for a novel TROP2 ADC, sacituzumab tiromatecan, which carries belotecan, another topoisomerase 1 inhibitor, as the payload. And here the drug-to-antibody ratio is 7.4:1. Currently, sacituzumab govitecan is the only FDA-approved TROP2 targeting antibody-drug conjugate for the treatment of breast cancer. There are two indications for SG. First, in patients with metastatic or unresectable locally advanced triple-negative breast cancer who have received 2 or more prior systemic therapies, at least one of those in the metastatic setting. And also for patients with unresectable locally advanced or metastatic hormone receptor-positive HER2-negative breast cancer who have received prior endocrine therapy and at least 2 additional systemic therapies for metastatic disease. So we'll start off by reviewing the data for TROP2 targeting ADCs and triple-negative breast cancer, and I'll pass this over to Komal to review this section.
Thank you so much, Anna, for setting the stage for these newer antibody drug conjugates, including the approved one that you mentioned, which is sacituzumab govitecan. So, yeah, let's first talk about how do we think about optimizing and integrating the use of these antibody drug conjugates specifically for our patients with triple negative breast cancer. We'll start with this case. This is Barbara, who's a 39-year-old woman who lives in rural Colorado. She was diagnosed with stage 1 triple negative breast cancer with HER2 IHC 0 expression and ER and PR of less than 1%, underwent a left lumpectomy with left axillary central lymph node biopsy that revealed a 1.2 centimeter grade 3 focus of triple negative breast cancer. 0 out of 3 lymph nodes were involved. She received adjuvant TC-based chemotherapy followed by adjuvant radiation. Unfortunately, 3.5 years later, she presented with liver and lung metastases. A liver biopsy was performed at that time and confirmed again triple negative metastatic disease with ER0, PR0, and HER2 IHC 0 expression. PD-L1 was positive with a CPS score of 20. Based on this, she started first-line treatment with paclitaxel and pembrolizumab. After 8 cycles of treatment, she developed some fatigue, dyspnea, and abdominal discomfort and was found to have disease progression with new lung and liver lesions that were detected on imaging. So keep this case in mind as we review the data ahead. And then we'll come back to this case later and see how do we think about this patient and how do we treat her in clinic. So starting with the ASCEND trial that evaluated and led to the approval of sacituzumab govitecan in patients with metastatic triple-negative breast cancer. So patients enrolled on this phase 3 trial, ASCEND, had received 2 or more prior chemotherapies for their advanced disease. So there was no real upper limit for the number of treatments they would have received in the metastatic disease. However, one of the required regimens could be from progression that had occurred within a 12-month period of completing treatment for early stage breast cancer or early stage triple negative breast cancer. 529 patients were randomized 1:1 to receiving sacituzumab govitecan at the dose of 10 milligrams per kilogram on days 1 and 8 of a 21-day cycle versus physician choice chemotherapy, which could be any of the 4 drugs, namely capecitabine, eribulin, vinorelbine, or gemcitabine. The primary endpoint was to look at progression-free survival, specifically for those patients who do not have brain metastases. So to further clarify, patients with stable brain metastases were allowed. No patients with active brain metastases were enrolled on study, and the primary endpoint excluded the patients with stable brain metastases and focused on those that did not have any brain metastases. Secondary endpoint included other efficacy endpoints such as progression-free survival in all patients, overall survival, overall response, duration of response, time to response, safety data, and quality of life. And here are the results on your left for the Kaplan-Meier curves for the primary endpoint of progression-free survival. There was a statistically significant improvement in progression-free survival from 1.7 months in the chemotherapy arm to 4.8 months in the sacituzumab arm, with a hazard ratio of 0.41. On your right are the Kaplan-Meier curves for overall survival. Again, there was a statistically significant improvement also in overall survival, a near doubling of overall survival from 6.9 months in the control arm to 11.8 months in the sacituzumab arm, with a hazard ratio of 0.51. And these data, needless to say, led to the approval of sacituzumab govitecan for patients with metastatic triple-negative breast cancer. Now, since this is a TROP2 ADC, there was an exploratory analysis that was conducted to see if there was a difference in progression-free survival by TROP2 expression. And shown here are the Kaplan-Meier curves for 4 quartiles for TROP2 expression measured by AIDS score. And what was seen was that benefit was seen in all 4 quartiles for sacituzumab compared to physician choice therapy. So it did not matter what quartile the patients were on, there was a benefit favoring sacituzumab over physician choice chemotherapy. I do draw your attention to certain quartiles which might have fewer numbers or the sample size is relatively smaller to the others. And you can see there the confidence intervals is also crossing 1. This was, however, exploratory analyses. And I think the point here is that we don't test for TROP2 as a biomarker when we're offering these TROP2 ADCs to our patients in clinic. What about the same analyses looking at overall survival by TROP2 expression? Again, there was a trend favoring overall survival benefit in the sacituzumab arm compared to physician choice chemotherapy based on the TROP2 expression in the 4 quartiles shown here on this slide. So the most common toxicity or the most common treatment emergent adverse event that was reported in 10% or higher patients in the ASCENT trial was neutropenia, seen at 64% as all-grade neutropenia. 52% had grade 3 or higher neutropenia. 6% had febrile neutropenia, which was grade 3 or higher. That was the most common toxicity with respect to treatment emergent adverse events that were reported. The second most common toxicity that was reported was also diarrhea. All grade diarrhea was 65%, and 12% of these patients had grade 3 or higher diarrhea. Now, Dr. Garrido-Castro did mention the third antibody drug conjugate targeting TROP2, which has also been evaluated in clinic, namely sacituzumab tirumotecan, where the payload is again a topoisomerase 1, but in this case a belotecan derivative, and the drug to antibody ratio, as she reminded us, was 7.4 for each antibody molecule that delivers payloads. So 7.4 molecules of payloads are delivered. Now, this was the OptiTROP Breast-01 trial, a randomized controlled open label phase 3 trial, specifically for locally recurrent or metastatic triple negative breast cancer. Again, these are patients who've relapsed or refractory to 2 or more prior chemotherapy regimens. For prior therapy, one could have been, again, in the early stage setting, provided the progression occurred within 12 months or during the 12 months of treatment discontinuation. The patient should have had received prior taxane, which could have been in any setting, early or late stage. Patients were randomized to sacituzumab tirumotecan. The dose for this antibody drug conjugate is 5 milligrams per kilogram every 2 weeks. Again, this was randomized to physician choice therapy, the same 4 drugs, eribulin, capecitabine, gemcitabine, or vinorelbine, for a primary endpoint of progression-free survival by blinded independent central review or BICR assessment. And so shown here are the results from the OptiTROP Breast-01 study. On your left are progression-free survival, which was the primary endpoint by BICR analyses, where we saw a statistically significant improvement from 2.5 months in the standard of care arm to 6.7 months in the sacituzumab tirumotecan arm. Hazard ratio was 0.32 with a p-value of less than 0.00001. On your right are the Kaplan-Meier curves for overall survival. These are interim analyses where we see median overall survival of 9.4 months in the control arm, which was not reached in the sacituzumab tirumotecan arm. And so longer follow-up data are awaited to see this mature overall survival analyses. With respect to toxicity, the most common treatment-related adverse events from sacituzumab tirumotecan and chemotherapy were hematologic toxicities, predominantly anemia, when nearly 25% or higher had grade 3 or higher anemia in the sacituzumab tirumotecan arm. Approximately a third of these patients also had neutropenia. Stomatitis was also seen with sacituzumab tirumotecan. All grade stomatitis was about 44%. Grade 3 or higher was 9%. We did not see a whole lot of diarrhea with this drug. There was dose reduction reported in 25% of these patients, and 1.5%, so a very low number, required treatment discontinuation with sacituzumab tirumotecan. We've also evaluated, or there's an ongoing study, I want to say, called the Morpheus trial, which is evaluating various combinations. And one of the combination cohorts was looking at sacituzumab with atezolizumab. And data from this cohort in the untreated, locally advanced, or inoperable triple-negative breast cancer was presented at the ESMO meeting. And this was a cohort of patients that was treated with this combination where the overall response rate was 76.7%. And this was in patients with PD-L1 positive tumors, which was assessed using the SP142 assay. So various such efforts are currently ongoing, including with datopotamab deruxtecan. Now, datopotamab deruxtecan has also been evaluated in the Begonia trial, and this trial really was designed to evaluate combinations of durvalumab, an anti-PD-L1 antibody, with other novel therapies in the first-line locally advanced or metastatic triple-negative breast cancer setting. So here we know it's the exatecan payload, and the drug to antibody ratio is 4. We're going to focus within the Begonia trial on Arm 7. Arm 7, which is highlighted here in the dark navy blue, evaluated the combination of datopotamab deruxtecan, which is administered at 6 milligram per kilogram every 3 weeks, in combination with durvalumab, which is also administered every 3 weeks. And this Arm 7 evaluated 30 patients. This was regardless of PD-L1 status that this combination was offered, and these patients were treated with this combination. And here are the updated results that were presented at the ESMO 2023 meeting, where median PFS for the combination was 13.8 months, and median duration of response was 15.5 months. What we don't know is what was the contribution specifically in the PD-L1 positive patients, which is Arm 8 in Begonia, which will be addressing that question more definitively. These are the updated safety results from the Arm 7 combination that we spoke about. Here, again, the most common toxicities that were seen with datopotamab are predominantly nausea, all grade 65%, no grade 3 or 4 nausea, stomatitis, which is a common side effect with datopotamab, all grade 65%, 11% with grade 3 or 4 stomatitis. We also see some ocular side effects, including all-grade dry eyes that were reported in 21% of these patients. With respect to dose reductions, about 29% require dose reduction with this combination. Treatment discontinuations were reported in 16% of these patients due to AEs. There was one patient who died on study with this combination. The patient died due to dehydration, which was unrelated to study drug therapy. Now, this combination is also being evaluated for early stage disease, which has become very interesting and a point of question because that expands beyond the role that we currently have for checkpoint inhibition in triple negative breast cancer. We already have approval for checkpoint inhibition with pembrolizumab based on the Keynote 522 regimen that we use for our patients in clinic. The I-SPY 2.2 is really a novel study that evaluates multiple combinations or multiple novel agents and evaluates their responses with data that we can get from surgery and other correlative analyses that can also be performed, which is really the strength of the trial. So I-SPY 2.2 design looked at multiple sequential regimens, which they called as blocks. Now, Block A had investigational agents without any standard chemotherapy across the response predictive subtypes, or RPS. Block B had optimal regimens based on the response predictive RPS and standard of care, and also investigational agents to improve responses. Block C included either AC or AC plus checkpoint inhibition per standard of care, and then patients underwent surgery. So here in this Block A, what was studied was datopotamab with durvalumab. Now, 33 patients went to surgery after Block A gave a favorable RCB value, which was predicted. Specifically, graduation threshold when we evaluated this cohort was not reached in any of the subtype, may it be HR positive HER2 negative or HR negative HER2 negative subtype. However, patients with triple negative breast cancer and those with immune positive subtype have a suggested higher likelihood of PCR rates. So after 4 cycles of dato plus durvalumab, it was effective and allowed 33% of the patients to go straight to surgery and skip the traditional chemotherapy. So skip the taxanes and skip the anthracyclines. It was particularly effective in the immune positive response predictive subtype, in that 43% of the patients in the immune subtype achieved a pathologic complete response after block A. The modeled PCR rate based on all data after block A is 65%. There were no new safety signals, and the toxicity profile for this combination was consistent with what we have seen with this combination, even in the metastatic setting or other prior studies. Similarly, we also now have data for sacituzumab govitecan in the early stage localized triple negative breast cancer setting. And this is based on an investigator initiated clinical trial called the NeoSTAR trial that really evaluated monotherapy of sacituzumab govitecan. The group that studied this initially presented the results for PCR rates, and with single agent sacituzumab, 30% of the patients achieved a PCR. Updated data with a median follow-up of 18.9 months showed that the 2-year event-free survival for all patients who achieved PCR was 100%. So in conclusion, the first neoadjuvant trial in locally advanced triple-negative breast cancer, sacituzumab did demonstrate single-agent efficacy and feasibility of response-guided escalation or de-escalation. And further research from this trial will really explore the optimal duration of sacituzumab govitecan and also additional combination strategies, including with immunotherapy for those that do not achieve a PCR. There are several ongoing trials that are evaluating TROP2 ADCs in advanced triple-negative breast cancer that are summarized here on this slide, including phase 3 trials of sacituzumab govitecan, namely ASCENT-3 and ASCENT-4, for PD-L1 negative and PD-L1 positive tumors, respectively. We also have the ELEVANT phase 2 study, which is also evaluating sacituzumab, and it's also evaluating the combination of magrolimab and sacituzumab in this study. We have datopotamab deruxtecan being evaluated in phase 3 trials in the TROPION-Breast02 and TROPION-Breast05 trials. TROPION-Breast02 is the first-line trial for PD-1 or PD-L1 inhibitor ineligible patients, and TROPION-Breast05 is for PD-L1 positive in the first-line metastatic triple-negative breast cancer patients, and that is being studied in combination with or without durvalumab. Sacituzumab tirumotecan is also evaluated in a phase 3 trial for triple-negative breast cancer patients. This is in PD-L1 negative tumors, where it is evaluating single-agent sacituzumab tirumotecan versus investigator choice chemotherapy. There are trials that are looking at these agents even in early stage trial that are summarized here on this slide and in this table, starting with sacituzumab in ASCENT-05, which is looking at in the adjuvant setting or in the residual disease setting, where patients would receive sacituzumab with pembrolizumab. Similarly, we're looking at datopotamab deruxtecan with or without durvalumab versus investigator choice, which is capecitabine and or pembrolizumab, again in the residual disease setting. We have datopotamab in TROPION-Breast04, which is in the neoadjuvant setting. We have sacituzumab tirumotecan for triple-negative breast cancer without a PCR, so again with residual disease setting, where the combination is being studied with pembro. And then the SACI-IO trial is evaluating sacituzumab both for triple-negative and HR positive with residual disease, where patients would be randomized to getting sacituzumab versus physician choice therapy. So a whole lot that will further inform our treatment paradigm for patients with triple-negative breast cancer, both in the metastatic and early stage setting. So let's go back to our case. So again, as a reminder, this was our 39-year-old from rural Colorado with stage 1 triple-negative breast cancer who underwent lumpectomy and sentinel node dissection for a 1.2 centimeter tumor that was grade 3, had adjuvant TC and RT, did develop metastatic disease 3.5 years later. The biopsy confirmed triple-negative PD-L1 positive tumor. She received 8 cycles of taxane and pembrolizumab and had progression of disease at that time. So, Anna, maybe I would ask you, how do you think about these patients and what kind of factors or data do you keep in mind when you're thinking about treatment in this setting after first-line checkpoint inhibition?
Yes, thank you so much, Komal, for that review. And in this case, I think certainly we need to take into consideration multiple factors, including the prior lines of therapy that patients have received, toxicity received, potential biomarker data, for example, results from genetic testing, if a patient carries a germline BRCA1 or 2 or PALB2 mutation, and also somatic NGS testing, which may open up other opportunities for either standard regimens or clinical trial opportunities as well. I think in someone who has progressed on first line therapy after paclitaxel and pembrolizumab, after also prior therapy in the early stage setting, this is a patient who would be a candidate for sacituzumab govitecan in the second line setting, and certainly would consider SG as a potential option. I think one question is, if the patient had a germline BRCA mutation, what treatment would you recommend in that setting? And with sacituzumab govitecan, we do know that there is overall survival benefit compared to standard chemotherapy options, though in ASCENT, PARP inhibitor, for example, was not included in the control arm for patients with germline BRCA mutations. So, and with the PARP inhibitors, we know that there is improvement in progression-free survival compared to chemotherapy, but no overall survival benefit reported in the Olympiad trial. So I think sacituzumab govitecan would be a reasonable option, but it is important to lay out the differences in dosing, schedule, route of administration. The PARP inhibitor is an oral medication, whereas SG is given intravenously on days 1 and day 8 of every 21-day cycles. And so one can discuss these options with a patient and then make a decision jointly based on all of this information.
I completely agree. Yeah, I think we definitely don't have any definitive data comparing PARP inhibitors with the antibody drug conjugates here in this second line setting. Certainly, before antibody drug conjugates, if the patient did have a germline mutation, we did think about PARP inhibitors as a very appropriate choice. I mean, in the instance when patients have both the germline BRCA mutation and PD-L1 positive status, do you think about a different approach in your first line choice there? Could you walk us through how you think about that scenario?
That's also a great question. And I think in the first line setting with chemotherapy in combination with the PD-1 inhibitor, there is overall survival benefit demonstrated as well. So I tend to utilize the combination of chemotherapy and immune checkpoint inhibition in the first line setting, but a PARP inhibitor can be used later on at time of progression.
There are some ongoing trials that are evaluating combinations with, PARP1 selective inhibitors, and I think that's a good reminder for us and our patients. If, you know, there are trial options they can discuss with their physicians. So, for example, there is a PARP1 selective inhibitor, ACD5305, which was being evaluated in combination with antibody drug conjugates. And so, if they had a TROP2 ADC plus a PARP inhibitor trial that was looking at that combination, that would be a great option for these patients in the second line. But short of that, I think I do agree. I think it's a great discussion with our patients: an oral drug versus an IV drug, but no overall survival benefit with the PARP inhibitor, and overall survival benefit with the TROP2 ADC. So multiple factors, including disease burden, come into play. What about if this tumor was HER2 low? How would that make a difference in your choice?
Also a fantastic question. So we know from Destiny Breast 04 that in patients with metastatic HER2 low breast cancer, after receipt of at least one prior line of chemotherapy in the metastatic setting, that TDXD significantly improved progression free and overall survival compared to standard chemotherapy. That said, in Destiny Breast 04, about 90% of the overall population had hormone receptor positive HER2 low breast cancer. Only 10% of patients had, in essence, triple negative HER2 low disease. But even in an exploratory analysis in the triple negative subgroup of DB04, there appeared to be numerical benefit favoring TDXD compared to chemotherapy, both for PFS and OS. And so I do think both options, both sacituzumab govitecan and TDXD, could be considered in the second line setting for someone with metastatic HER2 low triple negative breast cancer. Although we do have more robust data from randomized phase 3 studies for TROP2 ADC in this setting. So with the more robust data for the TROP2 antibody drug conjugate, I tend to utilize the TROP2 ADC first for patients with metastatic triple negative breast cancer. But I would ask, uh, after progression on sacituzumab govitecan in someone with HER2 low metastatic TNBC, do you consider sequencing ADCs in these patients who are candidates for more than one?
I think such a fantastic question. Again, a data-free zone, right? I think something that we don't know exactly how to approach, but we try and figure out how do we think about this. And we're getting some early data sets, where we're trying to learn from retrospective studies and real-world data. When we sequence these antibody drug conjugates, what does it look like? I think what has become a little bit evident, at least from these small data sets so far, is that perhaps what we achieved with the first antibody drug conjugate is rather longer and more durable compared to the second. What we don't understand is that second antibody drug conjugate still superior than chemotherapy? I want to say yes, based on historical data that we have. So I know our bar with our standard of care chemotherapy is so low that even though we don't see such a robust progression-free survival from the second antibody drug conjugate as a sequencing therapy, it might perhaps still be potentially better than our standard of care chemotherapy option. So I'm not opposed to that idea. But I think what, we don't necessarily also fully understand is what are the mechanisms of resistance here? Is there a resistance to the target? Should we be going after a different target? And would we have a better benefit with the antibody drug conjugate sequence that way? Is there a resistance to the payload? Now, both sacituzumab and trastuzumab deruxtecan are kind of topo 1 inhibitor payloads, but slightly distinct in terms of the potencies of this topo 1 inhibitor agents. So, could that be something that we have to keep in mind? So, I don't think that we have a clear answer yet. I've many a times justified eribulin in our patients when we have third line data and then thought about using TDXT. If the disease burden is very bothersome and the visceral disease is very concerning, I have justified trastuzumab deruxtecan immediately after because I'm nervous about this patient one way or another anyway. The one thing I would say in the second line setting, I agree with you completely. The robustness of the ASCEND trial in a phase 3 setting definitely trumps my decision for utilizing this for HER2-low patients over trastuzumab deruxtecan, which got approval based on 58 patients in the exploratory analyses from Destiny-04. I do think that if I had a scenario where patients with brain metastases wouldn't play, then maybe in that case, we have a little bit more data with TDXT with both active and stable brain metastases, and I would favor that as a decision for my triple negative patient with HER2 low breast cancer and utilize TDXT even sooner than SASI, only in that scenario. But sequencing, I feel like I've done both. Sometimes I've done eribulin and sometimes I've done TDXT. I'm hoping trial efforts such as TRADE DXT, which is evaluating TDXT and datopotamab deruxtecan, a registry that is being planned for patients who get TDXT and then standard of care sacituzumab or vice versa. Efforts such as those will hopefully help us address this question better. So more to come there. Any word on how do you educate or counsel your patients about what to expect during treatment, including adverse events?
Yes, also a great question. I think very important to review the potential side effects that both patients and providers should be keeping an eye out for while on treatment with sacituzumab govitecan. And I think in particular the GI toxicity, diarrhea, nausea, and management of that, and when also to alert the care team for development of side effects, and then also neutropenia, which often requires growth factor support while on study in addition to alopecia, which we see with sacituzumab govitecan as well.
Yeah, no, fantastic. I think so. A big take home point is we really need to encourage our patients to communicate back. We could only help them if we know exactly what's happening. And I think alerting them of what could be expected and reminding them to communicate back to the team will really help create a optimal endocrine adverse event management plan with our patients. So our patient who progressed on first line pembrolizumab and paclitaxel did start second line sacituzumab govitecan, and while receiving this therapy during cycle 1 did develop grade 2 diarrhea. So the question is, how do we manage this grade 2 diarrhea? How do we advise and educate our patients? I think we have to first see if the diarrhea occurred very early, so immediately the day of the infusion. Did it happen a few days later or later in the cycle? If it's early onset diarrhea, we can also offer atropine to our patients and include that as a part of their pre-medication. For late onset diarrhea, we certainly encourage them for diet modifications, communicating it back to the team so we can assess the severity of that grade, and also encourage them to immediately start anti-diarrheal therapy. And they could certainly let us know if, even despite that, they're having significant diarrhea, which would then warrant a dose reduction. So, as a reminder, less than 4 stools per day is grade 1, less than 7 stools is grade 2, 7 or higher number of stools per day is grade 3, and then life threatening consequences from this is grade 4. Certainly for grade 1 and grade 2, we encourage diet modifications and anti-diarrheal therapy. And if despite this, if these patients have recurrent grade 3 diarrhea, for example, we would definitely want to dose reduce them. And we can do up to 2 dose reductions before we discontinue if there is recurrent grade 3 diarrhea and despite 2 dose reductions. These are proposed management for selected gastrointestinal toxicities that are associated with sacituzumab, including nausea and vomiting as well. And certainly we can offer them antiemetics and encourage them for hydration, oral intake, which if it is definitely impacted with oral hydration, it's grade 2. And if it really requires hospitalization, it's certainly grade 3, which is when we would definitely offer dose reductions to these patients. With respect to what kind of prophylactic regimen can be offered for nausea, it's a 2 to 3 agent prophylactic regimen for nausea management that has been effective in clinic. Moving on to now optimizing and integrating use of TROP2 ADCs in HR positive, HER2 negative metastatic breast cancer.
Thanks so much, Komal. So now shifting gears to the HR positive setting, we'll also start with a case. This is Diana, a 62-year-old woman with history of an invasive breast cancer, a T2N2 grade 3, estrogen receptor positive in 90% of tumor cells, progesterone receptor positive in 50% of tumor cells, and HER2 negative by immunohistochemistry with a score of 0, who received adjuvant chemotherapy with dose-dense ACT followed by radiation, and then started an aromatase inhibitor in the adjuvant setting, which was taken for 4 years before discontinuing due to side effects. Approximately 7 months later, unfortunately, the patient developed right hip pain, and imaging revealed a lytic bone lesion. Staging scans were performed, which, in addition to bony metastases at the spine, hip, and ribs, also showed presence of liver metastases, and a biopsy of one of the liver lesions confirmed metastatic carcinoma that was ER and PR positive and HER2 again IHC 0. The patient had a germline testing, which was negative for pathogenic variants in BRCA1 or 2 and PALB2 as well, and received therapy with fulvestrant plus a CDK4/6 inhibitor with a sustained response and a progression-free interval of 28 months before developing asymptomatic progression in the bone and new liver lesions. At that time, somatic NGS testing via liquid biopsy was performed, which showed an ESR1 mutation without any other actionable alterations. And the patient went on to receive elacestrant, which later at time of progression was followed by capecitabine and subsequently at progression by paclitaxel. Ultimately, after progression on paclitaxel, a repeat biopsy of the liver was performed. And again, this patient had a tumor that was estrogen receptor and progesterone receptor positive and HER2 0. So let's keep this case in mind as we review the data, and we'll come back to this later to talk about recommendations for therapy. So sacituzumab govitecan is currently FDA approved for the treatment of metastatic hormone receptor positive HER2 negative breast cancer. And that approval came from the phase 3 TROPiCS-02 study. This was a randomized phase 3 trial for patients with metastatic or locally recurrent inoperable hormone receptor positive HER2 negative, including IHC 0 and low breast cancer, who had progressed after at least one prior endocrine therapy, taxane, and a CDK4/6 inhibitor in any setting, and who had received at least 2 but no more than 4 lines of chemotherapy in the advanced setting. Patients had to have measurable disease and were randomized 1-to-1 to receive either sacituzumab govitecan or chemotherapy of physician's choice, which could have been capecitabine, vinorelbine, gemcitabine, or eribulin. And the primary endpoint of TROPiCS-02 was progression-free survival by blinded independent central review. The study showed a significant improvement in median progression-free and overall survival with sacituzumab govitecan compared to chemotherapy physician's choice. Median PFS was 4 months with chemotherapy compared to 5.5 months with sacituzumab govitecan, and median OS improved from 11.2 months with chemotherapy to 14.5 months with sacituzumab govitecan. In a subgroup analysis of TROPiCS-02, you can see here that the benefits in terms of overall survival were relatively consistent across the different groups that are shown here, including exposure to prior endocrine therapy, lines of chemotherapy in the advanced setting, age, ECOG performance status, and also TROP2 expression. So similar to the data that Komal reviewed earlier for metastatic triple-negative breast cancer, in TROPiCS-02, there was an analysis performed also looking at outcomes for both progression-free and overall survival according to levels of TROP2 expression quantified by immunohistochemistry. And here you can see that although patients with TROP2 higher levels of expression of TROP2 appear to derive more benefit from SG compared to chemotherapy physician's choice, even in those patients with low levels of expression of TROP2, SG appeared to provide greater benefit than the standard chemotherapy in this study. And therefore, also in the HR positive setting, we do not routinely look for TROP2 expression as a potential biomarker for sacituzumab govitecan. In terms of common treatment-related adverse events that were observed in TROPiCS-02, you can see that this is relatively consistent with the data previously reported in metastatic triple-negative breast cancer, where the most frequent side effects included hematologic toxicity such as neutropenia, 70% rate of any grade neutropenia and 51% of grade 3 or higher neutropenia, and also GI toxicity with diarrhea occurring in 57% of patients. 9% of patients had grade 3 or higher diarrhea with sacituzumab govitecan. And also importantly, we do see alopecia with this antibody drug conjugate and others. Now, an important study is being conducted called the PRIMED study, looking at prevention of sacituzumab govitecan-related neutropenia and diarrhea, both in triple-negative and hormone receptor-positive HER2-negative metastatic breast cancer. And initial results were recently presented at ASCO, looking at prophylactic administration of growth factor support and loperamide to manage both of these adverse events. And you can see here in orange that the rates of neutropenia and diarrhea with prophylactic administration did appear to be lower than those reported in the ASCENT and TROPiCS-02 trials for TNBC and HR-positive disease. And the study is ongoing with global safety and efficacy results expected at the end of 2024. So it is possible that incorporating these strategies may help mitigate dose reductions and treatment interruptions, as well as permanent discontinuations due to these treatment-related adverse events. But what about combinations of TROP2 ADCs with other targeted or immunotherapy approaches? At ASCO, data for SACI-IO HR positive were reported. This is a phase 2 randomized investigator-initiated study that was conducted in patients with metastatic or locally advanced unresectable breast cancer, where patients were randomized 1-to-1 to receive sacituzumab govitecan with or without pembrolizumab. There was no restriction on PD-L1 status in this study, and patients had to have received at least one prior line of endocrine therapy for advanced disease or progressed on or within 12 months of adjuvant endocrine therapy. And patients could have received 0 to 1 prior lines of chemotherapy in the metastatic setting, so a slightly less pretreated setting compared to TROPiCS-02. Patients were randomized 1-to-1 to SG plus pembrolizumab, which was administered on day 1 of an every 21-day cycle, or SG alone. And the primary endpoint of the study was progression-free survival in the intent-to-treat population. And key secondary endpoints included PFS in the subgroup of patients with PD-L1 positive tumors, determined using the 22C3 assay in a combined positive score greater than or equal than 1%. And also overall survival, which was assessed in the intent-to-treat and PD-L1 positive subgroup. You can see here that the study did not show a significant improvement in median progression-free or overall survival in the intent-to-treat population with the addition of the immune checkpoint inhibitor to sacituzumab govitecan. Median PFS with SG plus pembrolizumab was 8.1 months compared to 6.2 months with SG alone. And median overall survival was 18.5 months compared to 18 months, respectively. However, interestingly, in the about 40% of patients enrolled on this study who had PD-L1 positive tumors, again defined by a CPS greater than or equal than 1, there was a non-significant numerical trend favoring the combination of SG plus pembrolizumab, both for median PFS and overall survival. You can see here on the left that in the patients with PD-L1 positive tumors, the median PFS for the combination of SG plus pembrolizumab was 11.1 months compared to 6.7 months with SG alone. And for overall survival, here noted on the left, in those patients with PD-L1 positive tumors, there was a 6-month absolute improvement in median overall survival from 12.5 months with SG alone to 18.5 months with the combination. Albeit overall survival data are immature, and the median follow-up at the time of these results was 12.5 months. Importantly, response rates were very similar between treatment arms, regardless of PD-L1 status. And so while this study did not meet its primary endpoint of significant of improvement in median progression-free survival in the overall population, this study does show an intriguing trend towards potentially synergistic activity of this combination in patients with PD-L1 positive tumors. And this is going to be further explored in another study that we'll talk about in a minute. In terms of the safety data for SACI-IO HR positive, the most frequent adverse events that were reported on study were those were as expected with sacituzumab govitecan alone, including hematologic toxicity and GI toxicity, and there were no new safety signals reported. But sacituzumab govitecan is not the only TROP2 ADC on the block. There are others, including datopotamab deruxtecan, and we've seen initial results from TOPION-Breast01, a randomized phase 3 study exploring the activity of Dato-DXd versus chemotherapy of physician's choice in patients with metastatic hormone receptor positive HER2-negative breast cancer who have received prior endocrine therapy and at least one line of systemic therapy. So in TB01, patients were randomized 1-to-1 to receive datopotamab deruxtecan or chemotherapy of physician's choice, which could have been eribulin, vinorelbine, capecitabine, or gemcitabine. And this study has 2 dual primary endpoints, including progression-free survival and overall survival. At ESMO in 2023, we saw the first results for TB01, which demonstrated a significant improvement in median progression-free survival by BICR analysis, with median PFS of 6.9 months favoring Dato-DXd compared to 4.9 months with chemotherapy of physician's choice. There was also an improvement in response rates with the TROP2 ADC from 23% to 36% with datopotamab deruxtecan. And overall survival data at the time of the presentation of this analysis were not mature, with a median follow-up of 9.7 months, and additional follow-up is needed for the overall survival analysis. Importantly, we can see here the treatment-related adverse events that occurred in at least 15% of patients on study, with rates of GI toxicity such as nausea occurring in 51% of patients who received Dato-DXd, lower hematologic toxicity rates than those reported with SG. Here you can see anemia and neutropenia reported as well. And some important adverse events to keep in mind with datopotamab deruxtecan, as previously noted, including stomatitis and dry eye. Here you can see the rates of stomatitis, ocular surface events, and also adjudicated drug-related interstitial lung disease with datopotamab deruxtecan in TB01, with any grade mucositis occurring in 56% of patients, 7% grade 3. For ocular toxicity, 40% rate of occurrence in TB01 and 0.8% of grade 3 events or higher, and then adjudicated drug-related ILD occurring in 3.3% of patients, with 0.8% of patients having a grade 3 or higher event. There are multiple trials ongoing that are assessing the efficacy of TROP2 targeting ADCs in advanced hormone receptor positive HER2 negative breast cancer, including ASCENT-07, which is comparing sacituzumab govitecan to chemotherapy in patients with hormone receptor positive disease who have not received prior chemotherapy in the advanced setting. Similarly, there are trials looking at sacituzumab tiromatecan compared to chemotherapy of physician's choice, including the TroFuse-010 trial, which is looking at sacituzumab tiromatecan with or without pembrolizumab compared to chemotherapy in patients who have received prior endocrine therapy and no chemotherapy for advanced disease. So, based on the preliminary data from SACI-IO positive, looking specifically at the combination of TROP2 ADC with and without the immune checkpoint inhibitor in this patient population. And importantly, there are also efforts ongoing to assess the activity and safety of TROP2 ADCs for patients with early stage hormone receptor positive HER2 negative breast cancer, such as the NeoStar trial, which includes a cohort for sacituzumab govitecan in the early as neoadjuvant therapy for patients with non-inflammatory breast cancer, and also a specific cohort for inflammatory breast cancer looking at sacituzumab govitecan with pembrolizumab in the neoadjuvant setting. And also SASHA, which includes a cohort for HER2 negative breast cancer, including hormone receptor positive HER2 negative breast cancer for those patients who have residual disease after neoadjuvant chemotherapy. So if we go back to our case, Diana, a 62-year-old woman who had a T2N2 hormone receptor positive HER2 negative grade 3 cancer, and after surgery received adjuvant ACT followed by radiation and an aromatase inhibitor for 4 years, subsequently developing metastatic disease that was biopsy confirmed hormone receptor positive HER2 0 breast cancer with negative genetic testing, and who subsequently received several lines of therapy in the metastatic setting, including fulvestrant and a CDK4/6 inhibitor, elacestrant, and 2 additional chemotherapies, capecitabine and paclitaxel. What treatment would you consider in this situation now after progression on these regimens? So, Komal, can I ask, what factors do you think about when making decisions in this setting? And would note here that the patient has had consistent biopsies of the liver and the initial breast mass that have been consistently HER2 0. So this would be a conversation about therapy for those patients who are not currently candidates for a HER2 targeted ADC, although perhaps we could also talk about the data for HER2 ultra low tumors as well.
Yeah, no, absolutely. So I think such a dynamically evolving area of interest here for us. I mean, we have trastuzumab deruxtecan that was already approved for HER2 low tumors for patients who have had at least 1 line of chemotherapy, no more than 2 lines of chemotherapy. And then came by the TROP2 ADC TROPiCS-02 trial that you summarized for us and reminded us of today, where they could have had up to 4 lines of chemotherapy. So a minimum of 2 and a maximum of 4. So this patient, certainly with IHC 0, could not be getting trastuzumab deruxtecan, which currently is only approved for HER2 low tumors. And so despite biopsies, remains HER2 0, and I think would have fit the bill for the TROPiCS-02 and could be offered there. In fact, our NCCN guidelines also suggest that sacituzumab could be even considered even earlier than what was studied in the TROPiCS-02 trial, including in the second line setting, should a patient's tumor consistently be IHC 0. And you can justify giving them this drug because they were not a candidate for trastuzumab deruxtecan even then. So even after capecitabine, if we really wanted to consider sacituzumab, that could have been a potential option. Now, the HER2 ultra low story came by from the Destiny-06 trial, which was presented at the ASCO annual meeting this year. And there are about 150 tumors in the Destiny-06 trial, which was predominantly designed to evaluate the role of trastuzumab deruxtecan as a first-line chemotherapy option for HER2 low tumors. But to further expand and broaden the patient population and and expand on the signal we had seen from the phase 2 DAISY trial, where we saw some responses even in the so-called IHC0 patients. Were they truly IHC0? Did they have some HER expression? Was the idea behind Destiny 06 allowing HER2 ultra low. So these are patients who have some HER expression, but it's less than 1 plus. And that's why it's called as more than 0, less than 1 plus, which was a central assessment that was conducted in the HER2 ultra low cohort in the Destiny 06. And we saw similar efficacy in that group. But this was 150 patients, 70 patients in the control arm, 70 roughly in the treatment arm. And so we yet are awaiting what the FDA will look at this data and say the efficacy signal certainly was interesting. So will we move towards what we do with TROP2 ADCs, where we don't have to check for a biomarker, and perhaps we could envision a world where HER2 could be also not necessarily tested? Or how are we going to fold in HER2 ultra low testing or justify other research efforts currently looking at quantitative biomarkers beyond IHC for HER2 testing is an area of ongoing interest. So I think more to come there. But today in clinic, I think this patient with IHC 0 and 2 lines or at least 1 line, it would be very appropriate for sacituzumab govitecan-based therapy. The question then is, you'd walked us through data for Tropion Breast 01, and we have tirubutican also being evaluated even in HR positive. So say we have more than one TROP2 ADC. How are we going to approach that situation, I think, for our patients? Also becomes very interesting. So there's one question about how do we think about TROP2 ADCs and HER2 ADCs? And then if we have more than one TROP2 ADCs, how are we thinking about that data as well? Maybe just walk us through how you will address that when that happens.
That is a great question, Komal. And I think the data that we have for TB01 for Dato-DXd is actually in a less pretreated patient population than the data from TROPiCS-02, right? Where in TB01, patients could have received 1 prior line of chemotherapy for advanced disease, and TROPiCS-02 was at least 2 lines of cytotoxic therapy. And so with that in mind, it will depend, if and when Dato-DXd gets approved, what that label, what the indication is and our guidelines endorse. But it does certainly open the option for Dato-DXd therapy earlier on in the course of metastatic disease. And it'll be interesting as we await data for some of the TROP2 antibody drug conjugate trials that are ongoing to see what the activity of these TROP2 ADCs is in an even less pretreated patient population. So perhaps after progression on prior endocrine therapy and no chemotherapy in the advanced setting. So eager to see the results from ASCENT-07 and how that may shape the order or sequencing of antibody drug conjugates in this space.
Yeah, it is definitely going to be very, very interesting. I mean, right now for the TB01, we don't have overall survival data. We certainly saw data in the 1 to 2 line chemotherapy patient population with a 2-month delta of benefit favoring datopotamab. And so, yeah, it'll be very interesting to see what ASCENT-07 shows. And are we going to be able to see overall survival benefits? When we saw those benefits with, say, TDXD, we did not have other therapies that had showed overall survival benefit. Now we have 2 drugs that already show overall survival benefit that patients will have access to. So will all the newer trials that are looking at overall survival benefit be able to show that? And how will we hold that data, or how would we think about that data? And what would the FDA do with that information? I think it's going to be very interesting of how we think. The other thing I think that might play an important role is I think our discussion with our patients about the administration schedule and the toxicity profile differences between these drugs. So datopotamab deruxtecan, I think, as we said, causes more nausea, stomatitis, and maybe some ocular side effects. Causes very little, interestingly, neutropenia and diarrhea, which is the predominant side effect we see with sacituzumab govitecan. And when we look at sacituzumab tirumotecan, I think, to me, it seems like it's in between sacituzumab and datopotamab. It does have some stomatitis. It does have some neutropenia. It does not have so much ocular side effects. There was one report of that ILD that we saw even with sacituzumab tirumotecan, which we don't see with sacituzumab govitecan. So I feel like it's somewhere in between the two. So I think it'll be very interesting. We have a Q3 week regimen, we have a Q2 week regimen, we have day 1, day 8 regimen, and some differences in toxicity profile. So all of this, I think, if we had all 3 available for patients, might also become an important point of discussion and engagement for shared physician patient decision making process. So I think more to come for us to discuss how are we going to address all of this in the near future. But maybe let's talk a little bit more about toxicity management, I guess, beyond diarrhea that we have already discussed, say for sacituzumab. Maybe we can talk about neutropenia and our experience with managing that.
Absolutely. So in this case, the patient started sacituzumab govitecan, and after the first cycle, on cycle 2, day 1, was noted to have a neutrophil count of 800. This was afebrile grade 3 neutropenia. So it is important. This is actually a relatively frequent side effect that we see with sacituzumab govitecan, and important to consider how we manage neutropenia with these antibody drug conjugates. And what we tend to utilize is growth factor support for grade 3 or higher neutropenia or febrile neutropenia, with short acting growth factor support for 3 to 4 days post day 1 dosing of sacituzumab govitecan. And we can consider also long acting growth factor support with pegylated filgrastim on day 9 of the cycle after that second dose of SG in the cycle as well. There are guidelines that suggest management of neutropenia with growth factor support, including dose reductions as well that can be performed if the patient does have recurrent neutropenia despite growth factor support. So you can see here that for grade 2 neutropenia, no dose modifications are required. But for grade 3 neutropenia, we do consider adding growth factor support for first events. And then if there is recovery in 7 days, we certainly can consider continuation of SG with growth factor support. But if there's recurrent a neutropenia despite growth factor support, we dose reduce sacituzumab govitecan. Or if there is a particularly prolonged period for recovery of neutropenia, that is also a situation in which we consider dose reducing SG. Another side effect that we discuss with patients when receiving therapy with sacituzumab govitecan is alopecia, which is quite common with SG and other antibody drug conjugates. And just some tips here that may be helpful include, discussing with the provider. One can consider a wig before starting therapy, and providers can provide prescriptions for this. And there are insurance companies that cover the cost for wigs, so checking for that in advance can be helpful. Also, a reminder of the importance of protecting the scalp from the sun by using sunscreen or wearing a hat or scarf is important. And interestingly, there are studies now that are looking at the safety and effectiveness of cooling caps, which we have used with taxane-based chemotherapy. And now these scalp cooling systems are being studied for patients who are receiving antibody drug conjugates such as sacituzumab govitecan or others. And so this can be discussed, although there are limited data currently for scalp cooling with SG and other TROP2 ADCs. So finally, as we think about the evolving landscape of TROP2 ADCs, and given the data from TB01, if and when datopotamab deruxtecan does become available as an option, we know that there are differences in the toxicity profiles as we were alluding to earlier. So Komal, if and when Dato-DXd is approved and becomes a new option for patients in this setting, what are some of those specific side effects or special adverse events of interest that you will discuss with the patient, and how would you recommend managing those side effects?
Yeah, no, I think such an important thing to keep in mind. And as we were saying, I think they're slightly distinct from what we have with sacituzumab govitecan. And I think the three most common things that I probably think about is one is nausea. So all grade nausea was about 65%. And I think the management would be similar to what we do with trastuzumab deruxtecan, where we would use a moderate to severe antiemetic prophylactic regimen, which really has been a game changer with olanzapine being added as well. So certainly I would do that even with datopotamab deruxtecan to manage the nausea. The two distinct side effects otherwise that stand out for datopotamab compared to sacituzumab are stomatitis and ocular side effects. And for the stomatitis, I think the key would be to do the prophylactic mouthwash. And I think those were the management strategies that were encouraged in the trial in TB01 as well. And certainly that was my experience when I was treating patients on the study, that kind of helped manage the severity and the grade of the stomatitis. Ice chips during infusions was an interesting guidance that was also provided. I'm not sure exactly what the independent contribution of that is, but that's certainly a guidance which I would continue to offer our patients to do that. And then for the ocular side effects, thankfully, these were all predominantly very low grade. And this was predominantly related to the fact that on the trial, patients were required to have ophthalmologic assessments every 3 cycles. And so obviously, when we were getting those assessments, we were finding these symptoms more so, because I don't recall when we talk to patients on, say, gemcitabine, Winnow, Eribulin, if we ask them about eye side effects, or necessarily that becomes a big discussion. And in fact, we did see a decent proportion of patients, in fact, higher than historical data on the control arm, getting those eye side effects. And so one of the guidance that has been provided is artificial tears. So I think those would be the two practical tips that maybe we can keep in mind if the drug, when it gets approved and becomes available to patients in clinic, that we really want to focus on so we can manage those side effects well. Ultimately, I think there are downloadable slides and practice aids that will also be available with specific recommendations and algorithms for managing stomatitis and ocular side effects that one will have access to, which I think is going to be key for us as practicing physicians to have access to and keep in mind as we start using these drugs, at least early on, before we become very, very familiar using them. Last but not the least, I think the rate of ILD pneumonitis was low with datopotamab deruxtecan. However, we did see a few reports overall in the program. And so certainly, again, to be vigilant about ILD pneumonitis the way we are, more so with TDXD, but while it's less in Dato-DXD, it can still happen. And we want to keep that in mind for TROP2 ADC, such as datopotamab.
Absolutely. No, I fully agree. I think the use of prophylactic mouthwash and artificial tears will be key for management of some of these adverse events. And I think regarding interstitial lung disease and pneumonitis, just underscoring the importance of promptly reporting any respiratory symptoms while on these therapies is key. So for patients to let their care team know if they do develop any new or worsening signs or symptoms, so that these can be managed promptly. So finally, Komal, we can talk a little bit also about the treatment advances in triple negative and hormone receptor positive HER2 negative metastatic breast cancer, but taking into context also socioeconomic factors, disparities, and inequities.
Absolutely. And I think this is really, really an important area, which expands obviously beyond TROP2 ADCs or triple negative breast cancer or hormone receptor positive breast cancer, something that I think we as a community have really begun to acknowledge more and more, and really want to focus more and more to avoid that inequity, if you will, for our patients. And certainly the current gaps and disparities when it comes to breast cancer, they have become increasingly algorithmized, but there remains clear disparities in the applications of these standard of cares across patient groups and populations, and multiple barriers persist. For instance, when we think about patients in rural areas, they have disadvantages with access to therapies. So coming to a tertiary care center might not be an easy thing for them to do. Low income or not having insurance or overall socioeconomic deprivation have also really caused a lot of delay, which translates into not only delayed diagnosis or late stage presentation, but also can come in the way of treatment adherence or optimal therapy that can be offered to them. And then certainly racial and ethnic disparities also have become a concerning factor when it comes to therapy, compounded by many minority groups that are being more likely to experience these disadvantages that we were talking about, that really translate into suboptimal care. So I think really, really important for us as a community to recognize this as an important issue, to figure out how do we address this or try and make this a little more equitable for our patients as much as we can. So this was actually a great example of looking at not just standard of care that we're talking about, but also about clinical trials where patients can get access to novel drugs by participating in these clinical trials. Many of these novel agents that are in clinical trials become available to these patients as standard of care. So much importance to really get enrolled into this, and having access to such options is such a big important need. And so this was really a patient-led survey that was conducted. So clinical trial participants should reflect the diversity, but the racial or ethnic minorities are underrepresented. In fact, if we look at the Afro-American or the Black patient population, only 5% approximately are enrolled on clinical trials, and in many trials, even less than that. And so Become was a research project that really aimed to better represent Black population in cancer research by increasing access to clinical trials. So what did it do? It really was a web-based survey of US adults that live with metastatic breast cancer, following a literature review and key informant interviews. There were about 400 patients that participated in this web-based survey, of which a fourth of this population, 100 approximately patients, were Black. And really what we found based on these surveys and these interviews, that 36% received as much information as desired. So only a third were really well informed. 2/3 wanted information from person with same racial or ethnic identity. Approximately 2/3 had difficulty finding trials. And about a third believed that treatment would be fair and equal. This just highlights that how much more improvement is needed in this field, in this area, and how much more we as a community of physicians can do in, in collaboration with our patient advocates, which reminds us that we have really partnered with GRASP in this program. And what is GRASP? It's really a patient-led organization that connects and empowers patients, clinicians, and researchers to exchange ideas and learn from each other. And it also believes in equity, inclusivity, and the power of science. It is committed to fostering inclusive partnerships and addressing disparities that really impact our cancer research and access to therapies. So really, we can learn more about viewing these downloadable resources and visiting graspcancer.org about this partnership and about what can be done together as clinicians, researchers, and patients to really make this equitable for betterment of our patients. So any key takeaway? I think this was a great session discussing all the data that we have for approved and upcoming TROP2 ADCs, and how do we address toxicity management, and how do we address disparities in cancer care. But any key takeaway, Dr. Garrido-Castro, that you might want to share?
Thank you so much. I agree. This has been a great session. And in terms of key takeaways, I think the message is that there are many new therapies over the past few years that have significantly transformed the treatment landscape for patients with advanced HER2-negative breast cancer, both triple negative and hormone receptor positive. And these antibody drug conjugates have demonstrated improvements in progression-free survival, and we're also seeing overall survival benefit with these agents. We are eager to see additional results from studies that are being conducted even in earlier lines and in early stage disease as well. And it may be that in the near future, these antibody drug conjugates may replace some of the standard chemotherapy options that we have that also are associated with other toxicities that can be spared. And so really so much research that is ongoing in the field, and really trying to understand better how the antibody drug conjugates work and what we could potentially do to improve the effectiveness of ADCs in new combination and sequencing approaches.
So thank you again for joining us today for the CME activity. It was a pleasure working with Dr. Anna Garrido-Castro today on this one.
Thank you so much, Dr. Jameri. It was a pleasure, and thank you all for joining.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, GRASP. This activity is supported by an educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, Visit peerview.com/RFN860.